You know, there are certain phrases in medicine that just immediately put a weird image in your head.
Mm.
And for this deep dive, the phrase that I haven't been able to shake since reading the source material is skin in the wrong place.
Yeah.
It sounds simple, right? Like a minor dermatological mix-up. But as we're about to find out, when skin gets into the wrong place inside your head, it turns into a bone-eating villain.
It's a surprisingly destructive concept. It sounds like a horror movie tagline, doesn't it? But it's actually the fundamental definition of one of the most dangerous conditions an ear, nose, and throat surgeon deals with.
Exactly. Today, we're doing a deep dive into chronic otitis media. And I want to set the stage here immediately.
Right.
We're not talking about the acute ear infection you had as a 5-year-old where you cried for a night, took some pink bubblegum medicine, and, moved on. We're talking about a chronic structural change to the architecture of the middle ear cleft.
That's such a crucial distinction. The source material for this deep dive comes from a comprehensive lecture series by the ENT resident, and they make it very clear that this is a disease of consequence.
A disease of consequence.
Yeah, it's a leading cause of hearing impairment in the developing world. It involves complex anatomy, some truly bizarre physics regarding how we hear, and high-stakes surgery where you're drilling millimeters away from the brain.
And what struck me before we even get into the gore and the puss, sorry, listeners, there will be fluids today, is the context.
Yeah.
This isn't just biology, it's socioeconomics. The source highlights that this condition is a massive marker for global health inequality.
It absolutely is. You see this triad of factors driving this, particularly in developing countries. You've got poverty, overcrowding, and malnutrition. It's a domino effect.
Yep.
Malnutrition weakens the immune system. Overcrowding means upper respiratory infections spread like wildfire. And those simple colds are often the spark that starts the ear trouble.
And then you add the lack of health education, right? If you don't know that a running ear is a bad sign, you just live with it.
Exactly. In many places, a discharging ear is just seen as a nuisance, not a medical emergency. By the time they see a specialist, the disease has had years to establish itself.
So let's get into the mechanics of what established means. The source defines chronic suppurative otitis media CSOM very specifically. It's not just my ear hurts. What are the boxes we have to tick to say, okay, this is chronic?
There are two non-negotiables. First, you need ear discharge.
Okay.
Second, you need a permanent perforation, a hole in the tympanic membrane, the eardrum. And when we say permanent, we usually mean it's been there for at least 3 months.
3 months.
Yep. If you have those two things, coupled with chronic inflammation, you have entered the territory of chronic otitis media.
And we aren't just talking about the eardrum itself. The source uses the term middle ear cleft. I feel like most of us have a cartoonish idea of the ear, a tube, a drum, and then some kind of mystery zone. But it's more of a system, isn't it?
Oh, think of it as a connected cave system.
A cave system? I like that.
You have the middle ear cavity itself, which is the main room. But in the front, it connects to the eustachian tube, which goes to your nose.
Right.
And in the back, and this is critical, it connects to the mastoid antrum and the mastoid air cells. These are honeycomb-like air pockets inside the bone behind your ear. When we talk about the cleft, we're talking about inflammation potentially affecting that entire cave system.
Okay, so the whole cave system is inflamed. There's a hole in the door, which is the eardrum, and fluid is leaking out. Now, this is where the source material provided the most useful framework for me. It talks about a great divide and how we classify this.
Yes, this is the single most important concept for anyone trying to understand this disease. Historically, doctors use anatomical descriptions, tubotympanic versus atochondral.
That's a mouthful.
It is, and frankly, it's confusing. The source emphasizes that the modern, practical way to think about it is much simpler. Safe versus unsafe.
I love that. It cuts right through the jargon. You either have the safe kind or the unsafe kind.
Right.
In the newer classification, these are called mucosal and squamosal.
Correct. Mucosal disease is the safe type. Squamosal disease is the unsafe type.
So let's unpack the safe one first. Mucosal disease. Why do we get to call it safe? Is it because it doesn't hurt?
No, it can still cause plenty of trouble. It's safe purely in the sense that it rarely creates life-threatening intracranial complications. It's usually confined to the lining, the mucosa, of the anteroinferior part of the middle ear. So think towards the front and bottom near the eustachian tube.
Okay, so if I'm a doctor looking into a patient's ear with the safe type, what am I actually seeing? I imagine it's not pretty.
It's definitely active. You're going to see a central perforation. Imagine the eardrum like a clock face. The hole is right in the center or maybe at the bottom. But the key is that the hole is surrounded by a rim of the eardrum. It doesn't touch the bone of the ear canal.
The rim is intact?
Exactly. And through that hole, you see the middle ear lining. It looks red, velvety, inflamed. But the giveaway, the thing you notice immediately, is the discharge. In the safe type, the discharge is mucoid.
Mucoid, meaning essentially snot.
Very snotty. It's distinctively slimy because it's produced by goblet cells in that respiratory lining. It is often profuse, meaning there's a lot of it pouring out. But here is the crucial diagnostic clue. It is generally not foul-smelling.
Okay, that's a big differentiator. Lots of slime, but no room-clearing odor.
And rarely blood-stained. It's annoying, it's messy, but it's not rotting. The bacteria are usually aerobic, like Pseudomonas or Staph aureus. It's often the result of an acute infection that just never healed up, or maybe a ventilation tube fell out and the hole never closed.
But safe is a relative term here. The source mentions that even this type causes damage, specifically a siccular necrosis. That sounds like the bones are dying.
They are. Even though the safe type isn't eating your skull, that constant bath of inflammatory soup creates enzymes. Those enzymes eat away at the tiny bones of hearing the ossicles. The source points out a specific, weakest link, the long process of the incus.
That's the anvil bone.
Right. The incus has this long, slender leg that connects to the stapes. That leg has a very tenuous blood supply. It's barely hanging on.
Ugh.
So when you have chronic inflammation, the blood supply gets cut off, the bone dies necrosis,
Oh.
and the connection snaps.
So the chain is broken, the sound can't get through.
Exactly. So you get significant hearing loss. Now, there was another massive warning in the source regarding the safe type. It was about oral polyps.
Yes. This part gave me anxiety, the do not touch rule.
It is the golden rule of ear examination.
Mhm.
Sometimes that inflamed velvety tissue pushes out through the hole in the eardrum and forms a polyp. It looks like a smooth, pale grape sitting in the ear canal.
And I can see the temptation. You see a blockage, you have tweezers, you just want to pull it out.
And that is a potential disaster. You must never avulse or blindly pull a polyp.
Because you don't know what's on the other end of the rope.
Precisely. That polyp isn't floating, it's rooted. It could attach to the stapes bone. If you pull the polyp, you might rip the stapes right out of the oval window. That opens the inner ear fluid to the air.
Oh, wow.
The patient would instantly lose all hearing and get violent vertigo.
Or worse, the facial nerve.
Yes, the facial nerve runs right through that area. If the polyp is attached to a dehiscence, an exposed spot on the nerve, pulling it could cause immediate facial paralysis.
Okay, so note to self. Leave the mystery grape alone.
Leave it alone.
Before we switch to the unsafe type, I have to ask about this specific paradox mentioned in the lecture. It's called the round window shielding effect. It blew my mind because it suggests that being sick helps you hear.
This is one of those aha moments in ear physiology. To understand it, you have to remember how we hear. Sound hits the eardrum, pushes the bones, and eventually pushes on the oval window of the inner ear. That creates a wave in the fluid. But for that fluid to move, it needs a relief valve to bulge out somewhere else. That relief valve is the round window.
Okay, so one window pushes in, the other bulges out. They work in tandem.
Right. They need to be out of sync, a phase differential.
Yeah.
Now imagine you have a big hole in your eardrum. Sound waves rush in and hit both windows at the exact same time.
It's a stalemate.
Exactly. The pressures cancel each other out. The fluid doesn't move. You hear nothing. But if the middle ear is full of that thick, slimy discharge we talked about, the fluid covers the round window. It acts as a shield.
It physically blocks the sound from hitting the relief valve.
Correct. So the sound only hits the oval window and the system starts working again. The phase differential is restored.
So the patient is walking around with an earful of fluid and they think, my hearing isn't too bad. Then you, the diligent doctor, clean it out, dry it up.
And they come back angry. Doctor, since you treated me, I can't hear anything.
It's because you removed their acoustic shield. You have to warn patients about this. The sickness was acting as a hearing aid. That is just wild. Okay, so that's the safe mucosal type. Slime, central hole, paradoxically better hearing when wet. Now I have to cross the divide. The unsafe type. Squamosal disease. Why does this one get the villain title?
Because unlike the mucosal type, which creates inflammation, this type creates invasion. This involves the attic, the upper part of the middle ear, and the mastoid. And the hallmark here is bone erosion.
And the main character is that skin in the wrong place concept. Cholesteatoma.
Yes, cholesteatoma. It's not a tumor, it's not cancer. It is normal skin keratinizing squamous epithelium that has gotten trapped inside the middle ear.
Why is skin so dangerous? I mean, I'm covered in it.
Skin on your arm is fine because dead cells flake off into the air, dust to dust. But the middle ear is a closed box. When skin gets in there, the dead cells have nowhere to go. They shed layer after layer, forming a sac.
It's a garbage bag that keeps filling up.
A garbage bag that expands under pressure. And the skin releases osteolytic enzymes, chemicals that digest bone. So it's physically expanding and chemically eating the skull.
How does the skin get in there? It's not like we're shoving skin into our ears.
The most common mechanism is retraction pockets. Imagine your euthydation tube isn't working. Maybe from childhood allergies. Negative pressure builds up in the middle ear. It acts like a vacuum cleaner. It starts sucking the eardrum inward.
Like shrink wrapping the inside of the ear?
Exactly. And usually it sucks in the weakest part first, the pars flaccida at the very top. This creates a little pocket. The pocket gets deeper, skin debris gets trapped in it, and suddenly you have a cholesteatoma sac growing into the mastoid bone.
Clinically, how do I tell this apart from the safe snotty ear? What are the senses involved here?
The smell, that is the big one. In unsafe disease, the discharge is usually scanty, very little fluid, but it is foul smelling. The source emphasizes persistent, offensive odor.
That's the smell of bone rot.
Bone necrosis and saprophytic infection. It's distinct. And because it's eating into granulation tissue, you often see blood. So scanty, smelly, bloody.
Now, there was a specific red flag mentioned called the ominous sign. Normally, if a symptom stops, we think we're better. But here, if the discharge stops, panic.
Panic might be a strong word, but certainly high alert. If a patient has a discharging ear for years and suddenly says, hey, it stops leaking, that is often not healing. It means a crust or a polyp has plugged the hole.
You've corked the bottle.
And the factory inside is still running. The pressure builds up rapidly. That pressure pushes the erosion faster towards the brain or the facial nerve. A sudden dry ear in a known cholesteatoma patient is a ticking time bomb.
This condition seems to be full of deception. We had the shielding effect for the safe ear. Is there a similar paradox for the cholesteatoma?
There is the cholesteatoma hearer.
Which again sounds like a very niche superhero.
Or a tragedy. Remember, this disease eats the ear bones, so technically the patient should be deaf. But sometimes the cholesteatoma mass itself grows so solid that it bridges the gap.
No way.
It physically connects the remaining stump of the incus or malleus directly to the stapes.
So the disease becomes the prosthetic bone.
It transmits the sound. So you have a patient with a brain-threatening disease, but their hearing test looks weirdly normal. The disease is masking the loss of function.
That's terrifying because hearing loss is usually what drives people to the doctor. If they can still hear, they might ignore the smell.
Precisely. And then, when you do the surgery to remove the disease, you remove that bridge. You cure them, and they wake up deaf. You have to manage expectations carefully. I am making your ear safe, but your hearing will drop until we can reconstruct it.
Let's talk about diagnosis. We've got the smell, we've got the location, but you can't just eyeball this with a flashlight, can you?
You really need a microscope. The source is adamant about this. You need to see the edges of the perforation. You're looking for pearly white flakes. That's the keratin skin debris.
And imaging?
A CT scan of the temporal bone is mandatory for unsafe disease. You need to map the extent of the erosion. There's a specific landmark the source mentions, the scutum.
That's the Latin word for shield.
Yes. It's a sharp, bony spur in the attic of the ear. It's usually the first thing a retraction pocket erodes.
Huh.
On a CT scan, if that sharp point is blunting of the scutum, you know you're dealing with a cholesteatoma.
Sharp is good, blunt is bad.
Exactly.
So we've diagnosed it. We know if it's safe or unsafe. Now we have to treat it, and this is where the paths diverge completely.
Completely. For mucosal, the safe disease, we start conservatively. We treat the infection. This involves oral toilet.
Which is a terrible name for a medical procedure.
It is, but it's accurate. It means cleaning the ear, suctioning out all that mucoid gunk under a microscope. Then we use antibiotic drops. The source suggests quinolones like Cipro because they kill the specific aerobic bacteria that live there.
Yeah.
And critically, water precautions.
Keep it dry.
No swimming. Cotton ball with Vaseline when you shower. If you keep it dry and clean, it often calms down. If the hole remains, you could do a tympoplasty later to patch it up.
Okay, patch the tire, good to go. But for the unsafe squamosal type, can we clean that out?
No. The source is very firm. Conservative treatment has almost no role here. You cannot clean out a cholesteatoma with drops. It's growing into the bone. It is a surgical disease.
And the priorities of that surgery are interesting. It's not just fix everything.
No, there is a strict hierarchy. Goal number 1, a dry, safe ear. You must eradicate the disease to prevent brain abscesses or meningitis.
Right.
Goal number 2, preserve or reconstruct hearing.
Safety eats function for breakfast.
Always. A deaf patient is alive.
Yeah.
A patient with a temporal lobe abscess. Maybe not.
The lecture goes into two main surgical strategies, canal wall down and canal wall up. This sounded to me like a home renovation decision.
It is.
Should we keep the dividing wall or go open concept?
That is a perfect analogy. Imagine the ear canal and the mastoid, the bone behind it, are two adjacent reams separated by a bony wall. The cholesteatoma is hiding in the mastoid rim.
Okay, I'm picturing it.
In a canal wall-up procedure, you preserve that dividing wall, you drill around it and behind it to clean out the disease.
So the floor plan stays the same?
Right. Patients prefer this because the anatomy remains normal. They can swim eventually, they don't need special cleaning, but it's harder to see everything. There's a higher risk of leaving a tiny pearl of skin behind, leading to recurrence.
And canal wall down.
You take the sledgehammer to the wall, you drill it away, and merge the ear canal and the mastoid into one giant cavity.
Open concept.
Total open concept. The disease has nowhere to hide. You can see everything. It is the safer option for eradicating disease.
Right.
But the patient is left with a large cavity in their head. It changes the acoustics. It collects wax and debris, so they need to come in for cleaning every 6 months forever. And usually, no water allowed.
So it's a trade-off. Canal wall up is better quality of life, but higher risk. Canal wall down is safer, but higher maintenance.
Exactly. And often, if the disease is expensive, the surgeon has no choice. They have to take the wall down to get the disease out.
Bringing this all back to where we started, when you look at the complexity of this drilling bone, specialized microscopes, lifelong maintenance, it really highlights why this is such a crisis in the developing world.
It puts it in stark perspective. If you are in a low-resource setting, you don't have the CT scanner to see the scutum, you might not have a drill to take the canal wall down, so the unsafe disease just runs its course.
Wow.
That's why the World Health Organization focuses so much on prevention. Treating the malnutrition and the hygiene that causes the infection in the first place is infinitely more effective than trying to reconstruct a destroyed ear later.
It's a sobering reminder that anatomy is destiny, but so is geography. Before we sign off, let's do a lightning recap, a cheat sheet for the listener who wants to spot this in the wild.
Let's do it.
Scenario A, central hole, lots of slime, doesn't smell bad.
Mucosal disease. Safe. Clean it, drops, keep it dry.
Scenario B, hole at the edge, in the attic, scanty fluid, smells like death, maybe some blood.
Squamosal disease. Unsafe. Cholesteatoma. Refer for surgery immediately.
Scenario C, you see a cute little brick-like polyp in the ear canal.
Hands off. Do not pull. Assume it is rigged with explosives. A facial wound.
You know, what I'm taking away from this deep dive isn't just the pathology, it's the strange ingenuity of the body. The way the fluid shields the window or the disease bridges the bone. It's like the body is desperately trying to hack its own system to keep the lights on.
It is. The body is incredibly resilient. It finds ways to adapt to failure. But in the ear, those adaptations, like the cholesteatoma cure, can mask the fact that the house is burning down.
Yeah.
It really highlights that the ear isn't just a passive microphone. It's a pressure vessel, an amplifier, and a biological barrier, all in 1 square inch.
And when it breaks, it breaks. A fascinating, if slightly terrifying way. Well, that wraps up our deep dive into chronic otitis media. A massive thank you to the ENT resident for the lecture material that powered this discussion.
Stay curious and please respect your discharge.
We'll see you on the next deep dive.